Hello and welcome to Best of the Day from the 21st annual meeting of the Network for Oncology Clinicians and Researchers meeting, once again this year in Las Vegas. This is day 2, and so in this 3-part segment of Best of the Day, we're going to cover first GU malignancies, then move on to GYN oncology with Dr. Rob Coleman, and then finish up later with thoracic malignancies with Dr. Corey Langer. But beginning with this segment with GU malignancies, I'm very happy to welcome Dr. Dean Bajoran from Memorial Sloan Kettering Cancer Center, and Dean moderated the GU session this morning. So Dean, thanks for being with us.
Thank you.
So it was an interesting session. I mean, some really good presentations and then some lively discussion afterwards. But I want to begin with David Nannis's talk on the evolving role of immunotherapy in GU cancers. Now, this several years ago would have been about a 5-minute talk, but now it's really expanded. I mean, we've all known about Sipuleucel T for some time in prostate cancer, but now all the immune checkpoint inhibitors, the data is probably a little longer and a little deeper in clear cell carcinoma of the kidney, but there is a lot of interesting data in your area of interest, specifically urothelial cancer. So give us an overview of what Dave Nannis had to say and where you see that field going.
So, well, first of all, we'll start with bladder cancer because, it's one of the, important areas that is undergoing study right now. So David presented 2 studies, one of which has been published in manuscript form, which is Tom Powell's data, published in Science, a good study, looking at a drug which is an anti-PD-L1 drug. So this is the MPDL 3280 drug.
Genentech drug.
That's
right.
Correct. And so this was part of an expansion cohort in terms of the study. So, they studied multiple diseases, saw a signal in bladder cancer, extended that to bladder cancer. All patients were typed, so to speak, in terms of their expression of PD-L1 and then treated. And the observation was that one is that this is a very active drug in patients whose disease has progressed despite chemotherapy, very active. And if you take a look at it in terms of immune recognition, we'll use PD-L1 expression as a surrogate for previously existent immune recognition of something in the tumor, that those patients who were high expressors, the response rate was 52%. Now, in those patients who had none or just barely perceptible 0 to 1 expressors, that was 14%. And if we take a look at just the best drug we have available in that setting, it's roughly around a 10 to 20% drug. Right. So even the so-called poorer subsets had a response rate that rivaled what we currently have available for the treatment of this disease. So that was number one. And that is that
these were platinum pretreated.
These patients. All these patients were previously treated, some with multiple prior therapies, but all had prior platinum, either carboplatin or cisplatin treatment. The second thing is actually what we call the swimmer's plots. So we're going to start seeing a lot of, we talk about waterfall plots, now it's the swimmer's plots. And that's really the most convincing observation, and that is when these patients respond, many of them respond almost immediately. It happens very quickly in the vast majority of responders. And the second thing is when they start, is those patients tend to have a very long response. And that's not something we've seen in chemotherapy at all. So even in the active drugs, response rate might be the same, but the durability of response is actually very brief. And now we're seeing very durable responses in that study. And then there's a separate study. That study was looking at MK-3475. That's a PD-1 inhibitor.
Pembrolizumab.
That's correct. And then that drug, study was presented at ESMO this past year. Same kind of observation in the sense of an active drug, 25% overall response rate. And if you look at the patients with regard to those swimmer's plots, a lot of durable responders. And so now that's opened up the space for all of bladder cancer. So we have trials that are ongoing in previously treated patients, first-line therapy in the metastatic disease setting. There are trials that are being planned for muscle invasive disease, and even trials now being planned for patients with non-muscle invasive bladder cancer at that very earliest stage. And if we think about bladder cancer, there's actually a whole body of literature that this is a tumor that is highly recognized by the immune system. We've had BCG for 40 plus years. We know that patients whose tumors have infiltrating lymphocytes do better historically than those who do not, in terms of surgical series. So we know there's been immune recognition. Now we're just letting that happen, so to speak, breaking that, that immune blockade.
So the data suggests that patients whose tumors are by immunohistochemistry high expressors of PD-L1 do better. Well, you mentioned the lymphocytes, so CD8 positive lymphocytic infiltration, does this seem to be a prognostic factor as well?
It does. In some of the studies so far, there are a number of biomarkers that are being examined. And obviously a biomarker is the holy grail. Can we identify the biomarker by which most patients would respond or not respond? I think this is different than what we've seen in chemotherapy. And that is, if you take a look at all these studies, PD-L1 is a dynamic marker. It turns on and turns off, and these studies actually went back and looked at PD-L1 expression in any tumor that they could find. It may have been paraffin-embedded tissue from years before. So we have to be very circumspect about these types of markers in terms of predicting response and non-response. And as I mentioned earlier, even the patients whose tumors did not show PD-L1 expression, we had responders in those patients, less than 1% of cells. So.
Does prior treatment with chemotherapy affect PD-L1 expression, so that if you are pre-treated with platinum, does that increase PD-L1 expression, or does it decrease it, or is anything known in that regard?
So right now, no. There are no definitive studies looking at PD-L1 expression based on the intervention, okay? There are some interesting studies in this field. So in melanoma, for example, when we look at a study of nivolumab with ipilimumab, there's actually a study showing that the patients whose tumors had the highest number of mutations were more likely to respond.
Right.
And the implication there is that if you have a lot of mutations, then you have a lot more in the way of neoantigens that are now expressed by the tumor and now recognized as foreign by the immune system.
So they're more immune stimulated.
Exactly correct. And if you take a look at what are the three tumors that have the most mutations, well, they're melanoma, non-small cell lung cancer, and bladder cancer are all right up there. And actually triple negative breast cancer is in that category as well. So that's number one. And then number two, actually just presented at the GU ASCO meetings, there were data showing that patients whose tumors were treated with cisplatin or platinum-based therapy, actually they were studied before and after therapy, and the use of cisplatin therapy increased the number of mutations in terms of these tumors. So one can make a hypothetical argument that maybe they are more likely to be responsive.
Selective pressure.
Or just, selective pressure, or just tumors that just have much more in the way of damage and therefore have unusual proteins on their surface recognized by the immune system as foreign.
So in renal cell, the trials have been going on a little bit longer, and we expect that one of the agents will be approved for renal cell fairly soon. Has most of the renal cell data also been in pre-treated patients who've already had VEGFR TKIs or whatever?
Yes, that's where most of the studies are now. But I think that if positive, and we're seeing responses, there are some pretty dramatic responses in terms of immunotherapy, and that's not surprising, given the longstanding history of immunotherapy in renal cell carcinoma, that there are responses. They are also durable responses, and we're going to see that move up very quickly, just like we have with all the other drugs. Yes, I think that's where we are.
So we asked Walter Stadler to give a presentation on his algorithm and take-home messages for renal cell carcinoma. And one of the subjects that comes up every year is the role of high-dose interleukin-2. And it's a very toxic treatment, but patients who do respond frequently do well for years and years. So what sort of guidance did he give us as far as which patients ought to be considered for that type of treatment? And of course, as we know, it should be done in a major center like yours or the University of Chicago or Walter's from.
Yeah, I agree. And so what Walter did is present the data with regard to high-dose IL-2. It's FDA approved, and the reason it was FDA approved that it does have a definitive long-term cure rate in terms of patients with metastatic disease. So that's why it remains an option right at the outset of treatment. So Walter talked about picking the right patient. So it's a small volume disease patient. Must have, as Walter said, must be in pristine medical condition. But patient has to have good cardiac and good hepatic function in terms of being able to tolerate the toxicities. And the other observation that's been made and that Walter spoke about is that it appears that the patients who meet those criteria, that high-dose IL-2 might be considered as the first-line therapy rather than after a TKI. Right. And that the toxicity appears to be a little bit greater from high-dose IL-2 in the patients who have been previously treated with a TKI. And then lastly, Walter made the point is that even though TKIs have a strong track record, it's mostly partial responders and not necessarily those complete remissions.
Right. And I wonder whether those patients who get partial responses might then benefit from immune checkpoint inhibitor therapy, and perhaps that would push their response over to a complete response.
We'll find out.
Yeah, I know. It's you know, my mind wanders off in those directions. So let's move on and talk about prostate cancer. We assigned Matthew Galsky a pretty exhaustive topic of both hormone sensitive and the quote castrate resistant prostate cancer. And there's been some data that everyone has been talking about since ASCO about the use of docetaxel with androgen deprivation therapy in patients who have progressive disease, but they're still hormone sensitive. So how do you select patients for that combination therapy? Who should get ADT plus docetaxel, or who should just get ADT? And what are you all doing in your center?
So this has become a very controversial point so far. So we have the Sweeney data, this study that was just presented. It's a randomized trial of ADT versus ADT plus docetaxel, looking at survival as the endpoint. And there was a stratification for high volume and low volume disease. High volume disease being 4 or more metastatic disease sites in bone. And that was defined right at the outset of the trial. And if you look at the long-term data, survival was better in the patients who got combined therapy. And when split by, or when there was a subset analysis, it looked like the greatest benefit was actually in patients who had high volume disease. And in fact, if you looked at the survival, the median survival was improved by roughly almost 1.5 years in that group. Now, this is a randomized trial, prospectively designed. The strata were well defined beforehand. The analysis was done based on those predetermined strata. So it's a well-performed study. It has not been published as yet, but it's being adopted into clinical practice by a number of people. Now, there are issues so far. One is it hasn't been through the peer review process. 2, there's a smaller study in Europe asking exactly the same question that hasn't been positive as yet. And so might it be that it's not as mature or that it's not as well powered in terms of the numbers of patients? So that's one aspect. The second aspect is as new drugs have become available to our armamentarium, there are some people who are saying, well, can we move chemotherapy farther off, because now we have newer generation drugs for the castrate-resistant patient that are available. So it's become a controversial area. It is considered a treatment option for patients. It has been adopted by some groups. I still think before it becomes a standard of care, we need independent validation, and we really need it at a minimum through the peer review mechanism.
Very good. So a caution, just don't jump in until we have a little more information.
Correct.
Very good. Let's talk a little bit about some of the work I know that's being done at Memorial and other places, looking at the molecular characterization of a number of malignancies, but especially bladder cancer and some of the other GU cancers, to try to find oncogenic drivers and even more important, actionable drivers that you can select the individual, or what we've been calling personalized therapy for a number of years. How is that moving forward, and what impact is next generation sequencing having on those efforts?
So it's really become a fascinating area. If we go back 2 or 3 years ago, we had very little information with regard to bladder cancer, actionable mutations or biomarkers that we could use to direct therapy. What we know now from the TCGA, which has been done in 130 patients, and then will total over 500 patients, and those data will be available very shortly, is that a number of mutations within the various pathways that we know of, from non-small cell lung cancer and melanoma, that there are mutations that are actionable. So, for example, there's a singular patient with a mutation of TSC1 and NF2 that is 5 years out from treatment with everolimus. This is a patient who progressed despite therapy, went on an everolimus trial, a major response sequence, and it turned out that that patient's tumor had these 2 mutations that made that disease exquisitely sensitive to mTOR therapy.
How frequently does that occur?
So it's very uncommon to have both mutations, but TSC1 mutations actually do occur with reasonable frequency. And in fact, in that study, we saw that patients who had TSC1 mutations, they were more likely to have biologic activity of everolimus. So now we know that, for example, PIK3CA is a mutation that's common, actually almost as common as in breast cancer.
Right.
FGFR3 is actually
fibroblast growth factor.
Exactly, and so that mutation actually is reasonably common. And there are 2 drugs that have been reported as active and are under study now for FGFR3 mutations. And then we have CDKN2A, which is very commonly expressed, and there are drugs that work on the G1S cell cycle.
Cyclin-dependent kinase.
Exactly right. So, and there are 2 drugs now that are in active study or soon to be started trials for those drugs. What we are seeing is that next generation sequencing is available to a large number of patients right from the outset, and that you can identify mutations that are potentially actionable. I think the conundrum that we're going to see in bladder cancer is which ones are the driver mutations and which ones are the passenger mutations. And although we may, for example, start a drug, for, let's say, PIK3CA, but we might also have mutations in TSC1 downstream from that molecule or in other pathways. And so that is sponsored studies looking at multiple drugs, and if a patient doesn't respond from what is considered a high likelihood driver mutation, you move on to the next mutation. So that's what's going on in bladder cancer. Today, actually, was presented interesting data with regard to prostate cancer. And that is that it looks like prostate cancer, that tumors that have splice variant mutations of the androgen receptor.
The ARV7.
Exactly,
Yeah.
that may confer or confer resistance to androgen deprivation therapy. So now there's a trial looking at using that as a biologic marker in terms of intervention. And I think, and that actually has been identified in circulating tumor cells. So I think that where we are looking at next generation sequencing with regard to tumors, we're moving now to circulating tumor cells. Pretty soon it'll be, cell-free DNA in the blood. Many of the groups are looking at what we call liquid biopsies to be able to identify the mutations, and so we don't have to go back to a tumor at one point in time that is subject to storage issues, et cetera.
So in the ARV7, it's the enzalutamide binding site that is chopped off of the receptor, so it can't have an effect?
That's correct. And actually the data are pretty compelling with regard to response and non-response. That's what makes it a fascinating biomarker in terms of using it to select for therapy.
These tumor cells are tricky.
Yeah, they are. Well, and what we're seeing as these platforms become more and more available, that we can identify biomarkers and now test them in terms of clinical activity. So we talked before about PD-L1. I don't think it's there yet. I've joked around that it might be the equivalent of P53 or what that was 10 years ago. It's an immunohistochemical test, et cetera. People are moving towards looking at subsets of tumor-infiltrating lymphocytes. Other groups are looking at whole exome analysis, looking at not only mutational burden, but specific mutations that might confer sensitivity. Groups in non-small cell lung cancer, for example, are looking at signatures, much like we do in terms of other diseases, like, for example, breast cancer. It's a fascinating time in oncology right now.
It is, and you've given us a great perspective on that data and all the information that was presented this morning. So I really appreciate your coming by and sitting down with us once again to talk about GU cancers and all the exciting things that are going on.
Well, thank you very much. It was a pleasure, Tim.
Thank you, Dean. And thanks to all of you for watching this segment. Please stay tuned. There will be more coming up on GYN oncology and thoracic malignancies. Thanks again. Hello and welcome back to Best of the Day from the 21st Annual NOCR meeting. This is day 2, segment 2. So in this segment, we're talking about GYN oncology. We just completed a great session with Rob Coleman and Brad Monk talking about ovarian, cervical, and endometrial cancers. So Rob, who moderated that section, has come up with us to sit down and talk about some of the information that was presented. So Rob Coleman is from MD Anderson, as I'm sure most of you know. So Rob, thanks so much for coming up and giving us your perspectives.
Well, thanks for having me. It's great to be here.
Well, I think it was, Brad, as always, gave a great presentation on ovarian cancer, and he is the ultimate showman and is so enthusiastic and so incredibly knowledgeable about things. So let's kind of just review quickly some of the discussion points with first-line management of patients who are optimally debulked, those who still have some residual less than 1 centimeter suboptimal disease, and then the patients for whom you need to try to debulk with chemotherapy before they're ready for the operating room. So give us your thoughts about those topics.
Yeah, sure. So I think one of the points that came up, and we talked about it right at the beginning, was what we considered as optimal. So in the past, we had data that went back as far as 1975 that showed that patients with less volume tended to do better when they got chemotherapy. What we've come to realize is that the less volume, probably the real differential, is those that don't have any visible residual. And that's actually kind of changed the way that we approach the disease, because now we're looking at a new patient with that thought in mind. So we look at their films, we look at their distribution of disease, and at MD Anderson, we're actually doing laparoscopy to assess whether or not they have debulkable disease, with the point being getting it all out. So, and Brad showed the very nice data that was from the compilation of our European colleagues that showed that patients that have no visible residual do dramatically better than those that have any residual. So the less than 1 centimeter kind of cutoff is probably not as relevant as it is the R0 or the no visible residual. So with that in mind, we have been coming up with treatment algorithms to try to assess both these groups of patients. I would say that globally, neoadjuvant chemotherapy is used fairly commonly. Probably much more than we would necessarily do that, and that probably has something to do with the expertise of the surgeons. Right. In this country, of course, gynecologic oncology is an amalgam of both surgical and medical oncology expertise. So when we take these patients to the OR and we think we can remove all their disease, the goal is really to do the maximal surgery to be able to get to that space. And when we do a triage mechanism, as what we're doing at MD Anderson and many other places now, that rate can actually get up well over 75% of where those patients are essentially rendered no visible tumor. For the others, then essentially the neoadjuvant chemotherapy approach is really done. with the intent of coming back to surgery to essentially try to achieve the same thing again. And one of the things we learned over the years was that patients who got neoadjuvant chemotherapy were actually much more likely to get a complete resection after, say, 3 or 4 cycles of induction chemo.
R0 is the ultimate goal for hopefully everyone.
Right, that's the idea. And I think there's been some controversy around, even in this country, because I think that many people say, listen, you know, that doesn't look debulkable. And so then they end up giving you adjuvant chemotherapy. And the controversy is really because patients potentially who could have been resected and then had 6 cycles of good chemotherapy were not afforded that opportunity. And so we're trying to really get our hands on who are the best patients to get surgery and who are the best patients to get neoadjuvant chemotherapy.
That's very interesting. And then what about the role of anti-angiogenic agents?
Yeah, sure. So you know, we've run a number of trials, and we've known for many, many years, more than 10, 15 years now, that the VEGF pathway is active in ovarian cancer, as it is in many other solid tumors. So the GOG and our European colleagues essentially ran 2 large phase 3 trials to assess the impact of bevacizumab, anti-VEGF antibody, in patients who have ovarian cancer. And in both of these, they used kind of a broad spectrum, all-comer kind of design. So they had both patients with large amount of disease and those with less amounts of disease. And essentially the trials had bevacizumab given through the chemotherapy as well as into the maintenance. And in GOG 218, there was a 3rd arm, which was to give it concomitant with chemotherapy, but then placebo as maintenance. And in the European trial, it was open label, but they didn't have that middle arm. And so, but the message was the same. Essentially in both groups, even though they used different doses, different duration, and different types of patients, the message was very consistent. And that's that if you add bevacizumab to chemotherapy, you can extend the time for which these patients' tumors come back. But in neither study did we actually see an overall survival difference.
That's interesting. Mm-hmm. So what about the PARP inhibitors? There was a lot of discussion this morning about PARP inhibitors, and now olaparib has been FDA approved. You mentioned specifically the way that, or maybe it was Brad, the way there's single strand breaks in DNA and double strand breaks in DNA, and how BRCA mutations play into this role. But there seemed to be evidence that the PARP inhibitors work whether you're BRCA mutated or wild type.
Mm-hmm. Exactly. So this is actually very exciting. I mean, it's nice to see something like this emerge out of from a preclinical setting, which was only in 2005. I mean, there were 2 reports in 2005, both published in Nature, that essentially showed that these cell lines that were deficient in BRCA function actually were sensitive to PARP inhibitor more than 1,000-fold. And so to see that translated into the clinic and into an approval in a decade is remarkable. So we're very excited about it. But what we've come to learn is that its benefit seems to be broader than the BRCA mutation germline carriers, which are the easiest patients to identify. And certainly we've had an ability to identify them for some time. What's new is that we are finding that in what we called the non-germline carriers, is that there are a group of patients in that group, in that cohort, who carry somatic mutations in BRCA. So they've been able to
acquired.
Acquired, yeah. Mm-hmm. And we've also found that there are other genes outside of BRCA that seem to be relevant for this synthetic lethality that you mentioned earlier, that we're seeing with these drugs. And so there's a lot of excitement about this because we're now developing the assays to identify who these non-BRCA mutation carriers but have this ability to respond to these drugs, who those people are. And a number of trials are ongoing right now, and the preliminary evidence, the data that Brad presented and some that's also been recently reported have shown that there is this 3rd bucket. You've got your BRCA population, and you have your true wild types who don't seem to respond. But then you've got this middle bucket, and those patients seem to be a new audience for us.
That's great, and I think that that's really going to be very significant, not just in ovarian cancer, but in other areas as well.
Yep.
So let's move on. And then after Brad was finished with ovarian, you took over and talked about cervix and endometrial. And you mentioned what a terrible worldwide problem cancer of the cervix is. And I remember it at ASCO just a year or two ago about these screenings that were done in India, where just not, the technology is just not available as it is here. So how big a problem is this worldwide, and what do you think the biggest problems are in this country as far as cervical cancer is concerned?
Yeah, I'm glad you brought that up, because I think people don't understand or don't have this understand what the global picture is for cervix cancer. More people, like 10 times more people, are dying from cervix cancer as people who are infected with Ebola. So it is a huge problem, and in many countries, it's the #1 killer of women.
And it's a terrible way to die.
Oh, and not only that, it happens in young people. These are people with little kids. We see it all the time in the clinic. It's tragedy, and it's even more a tragedy because it's completely preventable. Right. Vaccination rates are terrible globally, but we know it can work. In Australia, there was also nice presentation that showed in that environment where it's relatively captured audience, and by gender, both male and female are being vaccinated at early age, that that genital warts, for instance, are almost unheard of now, and that we anticipate this to have similar effect on cervix death. I'm glad you brought up the India example, because that study was amazing, because it took teenagers, girls, who went into these small villages and did essentially a triage visual application, a visual inspection to see whether or not these patients had disease. That level of intervention decreased mortality by 50%.
And it wasn't a pap smear, it was just a dye?
Just a look.
Yeah.
Remarkable. That was remarkable. And it was interesting, because that was countered at the same presentation in the same audience by GOG 240, which was a very large trial of chemotherapy versus chemotherapy plus bevacizumab, a very expensive treatment being done in the developed world, and here showing also an improvement in overall survival. So it was an important contrast, and I'm hoping that it raises the awareness of just how important cervix cancer management is globally.
In this country, what do you think is holding back more widespread use of the HPV vaccines?
Well, a lot of it's education. And there's politics involved as well, as you can imagine. I think at first our focus was on the girls, and that probably was a mistake to begin with. We know that in vaccination programs, that because this is a sexually transmitted disease, that we need to do both genders. So that's been a major holdout. There are people also who are afraid of vaccines, the toxicities. In Japan, they recently had a number of adverse events that caused the government to essentially modify their program for screening in reducing it. So there's been, and then how do you roll it out? So we do it mandatorily at school. How do you find the right audience? And so it's just an education thing. It definitely needs to be on our agenda all the time. We need to keep pushing it, because it's preventable.
Absolutely. Well, let's go back. You mentioned GOG 240, and tell us a little bit about the schema of that trial, and then what the results were and what impact it's had thus far.
Okay, great. So GOG 240 was a bifactorial design trial, so that there was a chemotherapy randomization, and then there was a bevacizumab versus no bevacizumab randomization. And it was set up through a series of studies leading up to that point, which identified that the platinum-based chemotherapies were the best. But we had concern that with the growing use of platinum-based chemoradiation, that maybe we might get more mileage out of a non-platinum doublet. And so there was some phase 2 data that suggested that the combination of paclitaxel and topotecan actually would be an active compound in this setting. Certainly topotecan has shown its benefit with platinum. So So that was it was the chemotherapy randomization, paclitaxel and cisplatin versus the topotecan and paclitaxel arm, and then of course plus or minus bevacizumab. So there were bifactorial design trial, and the first analysis that was planned was to look at the chemotherapy arms to see if there was any difference. And what we were able to see was that there was no chance that the non-platinum doublet would be better than the platinum doublet. And so
even in the patients with prior exposure?
Even with patients with prior exposure, yeah. So it kind of solidified that paclitaxel platinum doublet was actually quite important. And so then for the primary endpoint, which was overall survival, we looked at the chemotherapy plus or minus the bevacizumab. And what we showed was that we were able to improve not only progression-free, but importantly overall survival with the addition of bevacizumab, adding about 3.5 or so months on the median, but a reduction in the hazard for death by almost 30%. So a major advance. And I think that the slide I showed that tracked our overall survivorship with cervix cancer over the years of using before platinum-based chemoradiation all the way through to now, we have made a substantial improvement on the medians for women by this sequential step. I think the major question is, what do you do now?
Right.
Because it's hard to give 4 drugs, right? And we've always kind of just kept adding as we've gone along the way.
So let's talk about endometrial. In years past, we had Provera and megestrol acetate, and there wasn't a whole lot more to talk about besides those 2 agents. Adriamycin was tried and a number of other things. But it sounds like there's really some tremendous progress being made, especially as far as molecularly targeted therapy.
Yeah.
So bring us up to date.
Yeah, so you mentioned the hormonal route, and I think it's important to realize that a lot of endometrial cancer is endocrinely sensitive. What we've come to learn is that with the addition of the taxanes and the platinums, that now we've been able to come up with a better cocktail with those agents, essentially settling on paclitaxel carboplatin as a good backbone for patients with metastatic and recurrent endometrial cancer. But after that, choices are pretty limited. Right. We've looked at the angiogenesis inhibitors because that's seems to have single agent activity. But I think what's really been exciting lately is the analysis that came out of the Cancer Genome Atlas project that's focused on both endometrioid and serous cancers. And what we found was that there's a lot of actionable targets that are in these tumors. And so in terms of some of the new molecularly targeted agents, we're now looking down the PI3 kinase pathway and the MAP kinase pathways as potential targetable strategies for this disease.
Very good. So we've also talked at this conference so far, and we didn't really talk about it much this morning, but there's been tremendous interest in immunotherapy, immune checkpoint inhibitors. What is being done along these lines in the GYN oncology environment?
Well, there's a lot of interest. The data are pretty limited, but the interest is very high. I think in ovarian cancer, we have at least some data using a PD-1 inhibitor that showed objective responses. But interesting, and you've seen in some of the other tumor types, these long non-progressions, almost seeing the setting where you have very low in the way of response or progression-free advance, but you see the long overall survival. So those are starting to emerge. I think the experience we're seeing in some of the other HPV-dominant tumors, like in head and neck, I think are going to translate nicely into the cervix cancer world, and we're definitely doing it there. And then, of course, using them in combinations. There's important combinations that I think are going to be looked at in terms of angiogenesis escape and or in multiple different targets of immunotargets for all of the diseases.
Is there much evidence regarding PD-L1 expression in GYN tumors?
Yeah, so it's just like it is in all the other disease types. We're seeing staining in the tumors, we're seeing staining in the stroma. And so, identifying what's the best biomarker for those particular patients is still kind of being sorted out, but we do see it, yeah.
Good, all right. And what about lymphocytic infiltration? Is that very common in the solid tumors in endometrial or cervix or ovary?
Yeah, I think, we focused a lot on the tumor cell, and I think we all forget about what happens in the microenvironment. But yeah, as we start to look more and more into microenvironments, it's clear, just like it is in many other solid tumors, that that's going to be really important. And it's probably being induced. Chemotherapy alone, bevacizumab, and some of the other angiogenesis inhibitors, they're actually inducing these states. And we've got some preclinical data to suggest that the types of macrophages that are infiltrating in these tumors when they develop their resistance or escape from these strategies, particularly angiogenesis, are driven by these macrophage infiltrations. So the tumor-associated macrophages, their characteristics, and their ability to be targeted is absolutely on the forefront now.
So are we going to be hearing anything exciting at ASCO this year?
Well, yeah, I think there's going to be some, I would say at ASCO and at SGO. I put a plug in there, the chemotherapy results for GOG 213, which was a large randomized study looking at both surgery and chemotherapy. In this setting, it was paclitaxel carboplatin plus or minus bevacizumab, we reported at SGO. And we're hopeful to have an opportunity to present the quality of life data at ASCO. But yes, in endometrial cancer, we're expecting that 86P, which was that three-arm trial looking at paclitaxel carboplatin with various different combinations with a mTOR inhibitor or bevacizumab to that data. We may also see some of the data on GOG 252, which was a three-arm trial in frontline ovarian cancer looking at intraperitoneal and dose-dense strategies for ovarian cancer. Our European colleagues too, many trials that'll be coming looking at these alternative combinations.
We didn't really talk about intraperitoneal, but it's still something that's lurking in the background and still being used in some centers.
Yeah.
Very good. Rob, thank you so much. This was really interesting. You guys, you and Brad both did a tremendous job. You can just tell by the number of people that flocked to the front of the room to ask you questions. So we really appreciate your coming in, and I hope we'll see you back here next year.
Great, thank you so much.
Good. And thanks to all of you for watching this segment on GYN Oncology. Stay tuned. We'll be back with thoracic malignancies in just a little while. Thanks again. So welcome back to Best of the Day from the 21st annual meeting of the Network for Oncology Clinicians and Researchers. This is segment 3 of day 2, and we're getting together once again with Dr. Corey Langer from the University of Pennsylvania's Abramson Cancer Center to talk about this afternoon's really exciting session on thoracic malignancies. This was truly a tour de force with multiple faculty and a great discussion afterwards. And the whole session was led off by Corey talking about squamous cell carcinoma, a disease that really has been very difficult to manage. But there have been some improvements, and we'll go over that. So Corey, welcome to Best of the Day once again. Thanks so much, not only for moderating this afternoon session, but for sitting down with us to talk about it.
I appreciate it.
So let's talk a little bit about squamous cells. So beyond don't use PEM, what
bevacizumab.
Yeah, and that may be changing. So, and what else is going on in squamous cell as far as, frontline? What's the role of nab-paclitaxel? What do you do second line and salvage? And then the newest approval.
So it's really been a remarkable year in what I consider to be an orphan diagnosis, a diagnosis relatively common, but for which we really had not seen any headway in the last 10 to 15 years. There have been 3 separate positive phase 3 trials, either exclusively in squamous cell or including squamous cell, all reported since June of 2014. So the first was the necitumumab trial, the second generation EGFR monoclonal, which in combination with cisgem yielded a statistically significant, clinically modest, but real survival advantage. It remains to be seen if the drug will get FDA approval. If it does get approved, it remains to be seen whether it's going to be used as much, but it was really the first trial I'm aware of, a squamous specific trial that actually showed any exclusive benefit to this population.
And looking back at the FLEX data, was there any hint in squamous cell with cetuximab?
So there was some. So to remind everybody, the FLEX trial looked at vinorelbine cysts with or without cetuximab. And it was a positive trial. It actually made the plenary session at ASCO. It
Right.
did not translate into a FDA indication. But in both groups, in both adeno and squame, the hazard ratios were pretty comparable. In fact, it was a little bit better in squamous cells. So I think that was the impetus for studying the second generation EGFR monoclonal. And the absolute improvement in survival is on the range of 5%, but the separation persists over time. Again, I'm not sure if it's going to lead to an FDA approval. The other interesting agent, as you pointed out, was NABPAC. So it was a trial that was led by Mark Szynski a couple years ago, maybe 3 years ago, and it's been published since, that looked at weekly NABPAC without the interruption combined with standard carbo versus the standard carbo-PAC combination. And although it did not show either a PFS or survival advantage, clearly a major response benefit. Now, is that the NABPAC or is it just the schedule of the taxane? But it's become my go-to regimen, at least for frontline in squamous. A, it's FDA approved. B, at least in my experience, it seems to be better tolerated than the Q3-week 200 per meter squared or 175 per meter squared dose of paclitaxel. There's less neuropathy. And in my population, which is often quite elderly, the median age for lung cancer is about 71 in 2015. Right. There was a separate post-hoc analysis of that trial that showed a 9-month survival advantage for this weekly approach. Again, is it weekly taxane or weekly NABPAC? What we've particularly seen in the last, really just 6 months, was the emergence of a monoclonal antibody targeting angiogenesis that showed a survival advantage that was not restricted to non-squamous. Bevacizumab's approval is in the non-squamous population, but ramucirumab, which targets VEGF-R2 as opposed to the ligand, in combination with docetaxel, yielded a statistically significant, I'd argue clinically meaningful improvement in response rate, PFS, and at least a statistically significant improvement in overall survival. And
similar side effect profile to Bev?
Maybe a better side effect profile, because although we did see an increase in neutropenia and febrile neutropenia, we did not observe an increase in bleeding complications, which we had seen in the original. Thromboembolic phenomena, at least both in adeno and squamous, no major difference when it comes to toxicities. And that is in contrast to ECOG 4599, where the bleeding risks did go up, thromboembolic risks did go up. So maybe this drug will migrate into first line, one never knows. Until recently, for a very short period, this was a regimen I was starting to use in second line squamous, but now, just in the last 2 months since January of 2015, we've heard of this major trial, phase 3 trial, second line squamous only, comparing nivolumab, probably the first of many PD-1 checkpoint inhibitors compared to standard docetaxel, not only showing a survival benefit, and I would argue a major survival benefit. Median survival jumped from 6 months to 9.2 months. The p-value on this trial was 0.00025.
That's amazing.
Toxicity was far less with nivolumab. Overnight, this drug has become our standard for second-line squamous. So we're scrambling to get the formulary approvals in our institution, which interestingly will make docetaxel the third-line drug. So patients will probably get carbo, maybe gem or taxane. They'll then go on to nivolumab. Some of them will probably do extraordinarily well. Many won't. Again, it's another therapeutic arrow in our quiver. Right. It's not a panacea, but in a core group, at least in the phase 2 trials, about 15 to 18% had major response benefits, which were often quite durable even after the treatment ended. And then if they do have disease progression at that point, they'll probably go back to a cytotoxic. And I could foresee going with docetaxel and ramucirumab in that population, as long as their performance status is intact.
So we know that the immunohistochemical staining for PD-L1 has been looked at as a potential marker, but probably it may be just the technique of looking for it isn't that good, because even some people who are IHC 0 respond, and lymphocytic infiltration is another area that may be hint. But just from a clinical standpoint, was there any hint in the trial as to which patients might be the ones that are benefiting the most? The group in that 20-25%, any characteristics in that group that seem to be a commonality?
So in the phase 3 trial has not yet been fully unveiled. Basically, all we know is what's in the package insert. And unfortunately, the details regarding immunostaining have not been divulged as yet. In the phase 2 trial that really led to this phase 3, that was read by Suresh Ramalingam and reported just in October at the ISLAC Astro meeting in Chicago, PD-L1 was at best an imperfect marker. If the tumor was rich in PD-L1, the response rates were somewhat higher, but not significantly so. And responses were still observed in PD-L1 negative tumors that were frankly zero. And anecdotally, my best response, the patient in my practice with the best response to date to this class of drugs is clearly PD-L1 negative. So I think it'll be replaced by other markers. And one that I find really intriguing is mutation burden. Right. There are ways to actually gauge this. If you look at some of the other agents in this area, such as the Genentech Roche drug, the highest response rates have actually been observed in heavy smokers, in former or current smokers, often KRAS mutant patients, somewhat lower response rates in EGFR mutants who tend not to be smokers.
So the presence of PD-L1 is not going to be a requirement in the FDA approval?
Not for Nivo. For nivolumab, this was strictly a histology discriminant squamous cell. PD-L1 status was not a criteria for eligibility. For some of the other trials, it may be. There are ongoing trials frontline comparing this class of agents to standard platinum-based combinations, and there, because it is frontline, they are stipulating PD-L1 positivity. So if those trials actually prove positive, that will translate into the package insert. The problem is every single company has a different assay. Some are looking at the tumor cells, some are looking at the immune cells infiltrating the tumor, some are looking at the stroma. They have different cutoffs for IHC. There is no uniformity in how this is being assayed.
We need standardization.
It's going to be a nightmare in terms of both standardization and reproducibility.
What about adenocarcinoma? We've all got it kind of used to frontline. You use a platinum and pemetrexed. But Suresh Ramalingam talked a little bit about some comparative studies that would seem to indicate that maybe cis-docetaxel is just as good as cis or carbo-pem.
I think, which is true, but I would far rather give my patients carbo-pem ahead of cis-docetaxel. Granted, cis-docetaxel are generic agents. They're relatively inexpensive. And if I was in a cost-constrained environment, and we are increasingly, that might be my go-to regimen. But carbo-pem is far better tolerated. Yeah. Patients do not lose their hair. They don't develop neuropathy. Long-term use of docetaxel, of course, can lead to peripheral edema, to HSR side effects, even stomatitis, which I do not typically see with carbo-pem. There's some stomatitis with pemetrexed, but not much. Without question, my nearly 30 years of practice, carbo-pem has been in my experience, the best tolerated combination I've ever dealt with in lung cancer, and now is my go-to regimen in non-squamous. I think the big issue is how or when to give angiogenesis inhibitor in this population. So 50% or more of non-squamous are candidates for an angiogenesis inhibitor. Bevacizumab is still the upfront agent. We have the Point Break trial that really showed no major difference between PEM carbo-bev and PAC carbo-bev, so you can sort of take your pick. But again, based on toxicity, PEM is better tolerated. Suresh Ramalingam's ongoing 5508 trial will address a very important issue. What is the best maintenance approach?
Right.
Should it be BEV? Should it be PEM? Should it be the combination? It'll be the definitive trial, I believe, in maintenance
There seemed to be some difference in the panel among which some prefer PEM, some prefer BEV, some prefer both. So it is certainly a clinical trial worthy
It's a very
point.
practical clinical
Yeah.
trial. And if it's
Absolutely.
positive for survival, it'll change the indications for both agents. And if it's not, we will have to grapple with picking one or the other, because both are indicated in maintenance.
So Ronnie Mira talked about some of the identifiable oncogenic drivers that are now, many of which are targetable, especially the EML4 ALK fusion, ROS1, and some of the less common ones, RET and HER2 and all this. So we have crizotinib for ALK fusion and for ROS1. Ceritinib has now been approved for people who fail crizotinib. What other drugs are coming down the line?
Well, there's at least two that of fast track designation. One is alectinib, again from Roche Genentech, which in East Asia had nearly 100% response rate frontline.
Chugai originally.
Chugai originally, but now is, at least for development in North America, has been taken over by Roche Genentech. Second line response rates in the 55-65% range, better tolerated than ceritinib.
Right.
That's something that did not quite come through as boldly as it may have, but certainly the GI toxicities of all of the agents, frontline crizotinib, the second generation agents, including ceritinib, alectinib, and brigatinib, the AP26113 drug, ceritinib has the greatest toxicity. AP26113 is also being looked at actively. There's an ongoing randomized phase 2 in the second line setting, comparing two separate doses, one of which they'll settle on. The response rates, again, are about 60% in treatment-naive patients, as with the Chugai compound with alectinib. Response rates approach 100%.
Yeah.
We've never seen something like this before in non-small cell lung
amazing.
cancer. So second generation is here to stay. The big question is, what's coming for third generation? And I think as time goes on, it becomes more and more important to get tissue biopsies to see whether new mutations are emerging, whether the original oncogenic driver persists. And additionally, as time goes on, we are really seeing the advent of liquid biopsies. There are several different companies out now that will look at circulating free DNA from tumors.
So not just circulating tumor cells, but circulating
Actually,
free
circulating
DNA.
free DNA and assay that for the same markers. This is important in patients who have inaccessible tumors or bone-only disease, where we, in the process of decalcifying the biopsy, we denature the DNA and really can't do a proper molecular assay. So I think one thing that we did not really focus on, but is really going to change practice in the next 3 to 5 years, is this switch or this transition from tissue biopsies to liquid biopsies. We're going to do it more often, and we're going to do it in more patients more quickly. Much easier to get a blood draw than schedule someone for a core biopsy. And at least in terms of our efficiency, it's going to revolutionize how we care for non-small cell.
Is there a dominant mechanism of resistance in crizotinib-treated patients or ceritinib-treated patients, or is it a whole wastebasket full of problems?
It's a wastebasket, and it's still in the realm of uncertainty. A lot of it is unknown. KRAS mutations have been identified. EGFR mutations have been identified. Amplification of the original ALK has been seen. And presumably there'll be different approaches tailored to the specific abnormality.
Very good. Let's move on and talk a little bit about EGFR. Erlotinib has been the standard frontline drug. We know that afatinib is now available. It's an irreversible inhibitor. Maybe a little bit better, but maybe a little more toxic. But once you go beyond, and just about everybody does become resistant, T790 is the most common. I think ANSO said 60% of the cases are T790M mutated. There are drugs coming down the line that directly target that exon 20 mutation. Tell us a little bit about those.
So there are two compounds that have been fairly well developed in just the last 2 to 3 years. The Clovis compound, CO1686, or rosiletinib, generated response rates of 55 to 60% or so in patients who had initially responded to a first-generation TKI and then had progressive disease. These responses are often quite durable. Because this compound does not target EGFR wild type, we do not see the diarrhea or rash that are typically associated with erlotinib or afatinib. It does, however, have a side effect that seems to be unique to this compound, and that's a hyperglycemia. It's not true diabetes, but it may be interaction with IGFR. And by and large, the majority of patients getting this drug require a second drug to control their sugars. And we frequently use metformin or other oral compounds.
Which may have some anti-neoplastic
perhaps,
effects, yeah.
all the better. Sort of like B12 with pemetrexed. What could be better than adding a B12 shot to your chemo? But so metformin in epidemiologic studies has actually been associated with lower cancer risk and actually perhaps better response rates. But those who are already diabetic, already on an oral agent, will frequently require insulin at that point.
Now, do the new drugs, the Clovis agent and the AZD agent, do they also target the exon 19 and the exon 21 L858R?
So they both target the mutations as well as T790. So needless to say, ruxolitinib and the AZ drug 9291 are going to be looked at or actively being looked at front line.
Yeah, absolutely.
And the hope, of course, is that they'll result in progression-free survival rates that'll be 6, 8, 12 months better than we typically see with erlotinib and afatinib, in which case it may displace those compounds. On the other hand, you may get the same benefits sequencing from erlotinib to those compounds. So at the end of the day, it may not make a big difference in overall survival. The other trial I think that was very important from a practical standpoint was the IMPRESS trial. Because standardly we go to chemotherapy when these patients have progressive disease. And there have been many that have been quite dogmatic about continuing an EGFR TKI even beyond progression. We certainly don't like to stop it abruptly because we see tumor flares.
The idea of intercalating the
well, that's one approach. The other approach is that there will always be some component of the tumor that will, it's sort of like prostate cancer where you keep folks on androgen blockade indefinitely. But there was a very interesting study from East Asia that looked at individuals who had responded and then progressed on or had progressive disease on a frontline TKI, and they compared chemo alone to chemo plus continuation of of gefitinib in this case. And for absolutely no additional benefit. Response rates were identical, PFS was identical, and if anything, survival was worse with the continuation of a TKI during chemotherapy.
So hold the TKI until after the chemo is finished.
Once you start the chemo, but don't hold it for a long period before the chemo because we do see tumor flares. So most studies now accommodate that. Traditionally, in clinical trials, we would have a 3-week or 4-week washout period before you'd go on to the clinical trial. For the TKIs, it's 3 days, and the same holds true for the ALK inhibitors. 3 days. We've seen tumor flares in both populations.
Well, Govindan gave a very exhaustive oncology, thoracic oncology pipeline talk with a tremendous amount of science, much of it right over my head. But he did, one of the things he talked about were the cyclin-dependent kinase inhibitors, and palbociclib has already been approved in breast cancer. There was another one that he mentioned. I mean, that this is a mechanism, a driver in a number of non-small cell lung cancers. Are there trials ongoing in squamous particularly?
Yes, there are. So the master protocol, which is really one of the approaches. You have the umbrella approach or the basket approach. So the master protocol is an example of the umbrella approach. You take a specific disease type, and rather than running separate trials of different drugs, you have a master protocol that takes all comers, does molecular profiles in these patients, and then assigns them to a particular cohort or bin based on that molecular profile. And those who have CD4, CD6, or CD8 go on to this agent versus standard chemo, or now nivolumab, since that's approved for second-line squamous. Other inhibitors for FGFR, for hepatocyte growth factor, and then a separate cohort that is non-biomarker identified that's been looking at checkpoint inhibitors. And at this point, we'll probably look at checkpoint combinations because nivolumab is the standard. That trial will actually morph into a third-line trial because nivolumab will be the standard second line, and we'll still have the same questions third line. The other approach, which I think is very important, is what I call the basket approach. You identify the marker. So for instance, Merck has done this with pembrolizumab using PD-L1, as imperfect as it is, but IHC as a marker for trials. And then in the same trial, 22 different diagnoses. So small cell, mesothelioma, triple negative breast. But as long as they have the marker, they can go on to the trial. IRBs, you would never have enough depth or personnel to run separate trials for each of these entities, and you'd never accrue sufficiently. But in this era of molecular-driven treatment, I think we have to look at both approaches.
Very good. Corey, thank you so much.
Thank you for having me.
Always great to get together with you. You know the data so well, and it's just really nice to get your perspective on everything.
Thank you.
Very good. So thanks to all of you for watching this final segment of day 2 of the Best of the Day from the 21st Annual NOCR meeting. We hope you'll watch all of these discussions, and we hope that next year you'll decide to come to the meeting. So we'll hope to see you then.